Good morning all. We'll be having a short discussion on a case of primary bladder neck obstruction. So we had a 14-year-old boy who presented to us with vague abdominal pain. His ultrasound scan showed gallbladder calculus and ectopic kidney in the right iliac fossa, which was small in size, a normal left kidney, pre-void urine of 197 cc and post-void residue of 25 cc. We decided to do some further investigations, which included a DMSS scan for renal function and a uroflowmetry along with the routine blood investigations. The DMSS scan showed ectopic right small kidney with pyelonephritic foci. The function of the right kidney was 22% and the left was 78%. You can see the images. We did a uroflowmetry. He voided 276 ml of urine. His Qmax was 7.9 ml per second and it was a flat curve. So we proceeded with an RGU X-ray. The X-ray seemed to be normal as it is in the images. We decided to do an MCUG scan after that. We can see in the MCUG scan there is a reflux on both the sides. On right side it was a grade 4 reflux and on left side it was grade 3. This was followed by a urodynamic study. So as you can see in the study in the third row from above, the bladder had a reduced compliance with an unsafe bladder pressure despite being a vesicoureteral reflux present. The flow pressures were very high with a very poor flow, suggesting bladder outlet obstruction. So the similar findings were found in a repeat cycle of urodynamic study. A video urodynamic picture showed that the bladder neck was not opening well when the voiding command was given, suggestive of primary bladder neck obstruction. The uroflowmetry in the UDS also showed a flat curve with a very poor flow of urine. So the final outcome of the UDS was an unsafe storage pressure, which was 32 cm H2O with a poor Qmax and a Pediatric at Qmax being 110 cm H2O. And the bladder neck was not opening well in the video urodynamic images. So we counseled the patient and the parents for a bladder neck incision. So this is the cystoscopy findings. The anterior urethra was normal. This is the membranous urethra, the verumontanum and the prostatic urethra. We can see the bladder neck is not wide enough. So we decided to proceed with bladder neck incisions. Now this is the completion of cystoscopy. The bladder looked somewhat trabeculated. Both the uriphyses were little patulous, suggestive of vesicouretic reflux. There are various ways of doing bladder neck incisions. We can use a laser machine or a bipolar machine. We have used a laser machine. It's a thulium laser with a setting of 1.5 joules and 20 hertz. We wanted to do an ejaculation sparing incisions considering his age, so that means we stayed a centimeter away from the verumontanum. Either we can make a single cut at 6 o'clock position, or we can make two incisions at 5 o'clock and 7 o'clock position. I have seen that a continuous fire of laser makes a better cut instead of firing the laser intermittently. Initially it might be a little bit difficult, but as we keep on doing the procedure, the cutting becomes better. The another issue is little bit dangling of the laser fiber in the cystoscope. So I was using a pediatric cystoscope here, so a little bit the laser fiber keeps on dangling, but otherwise the procedure is quite simple. So we need to keep on seeing the ureteric orifice, so as a guide that our cut doesn't go too much inside the bladder. And since we wanted an ejaculation sparing procedure here, we keep on seeing the verumontanum in between and stay at least a centimeter away from that. Also, if you can see in the starting of the video, I have put an 18 gauge intracath suprapubically into the bladder, which acts as an outlet for our fluid, just like how we have inlet and outlet in TURP procedure. So this might a little bit help for the better vision during the procedure. Now usually a 6 o'clock single incision might suffice to open a bladder neck quite well, but in this particular case, since the kid had a solitary functioning kidney, we wanted the bladder neck to open very well and to reduce the bladder pressure to safeguard the only functioning kidney. So we decided that we'll do 2 incisions at 5 and 7 o'clock position. So this is the incision happening at 5 o'clock. There will always be a little curiosity that is the incision deep enough or are we still superficial? There are few clues which might help in make us the decision. We would prefer to have a bladder neck which is quite flat to the trigone. Also, we can compare the bladder neck before and after the incisions are made. Another option is we always do a Credes maneuver before starting the procedure, so we fill the bladder and see how is the flow of urine, so that we have something to compare in between or at the end of the procedure. So whenever we feel that our incisions are enough, we fill the bladder, we remove the scope and see if there is a significant change in the flow of urine. So that gives us a little bit idea that the incisions which we have made to open the bladder neck, are those enough or do we need to go a little bit deeper. So as you can see, the incision is happening on 7 o'clock position now. It is just like how we have done at 5 o'clock position. So at this point I felt that the incisions are deep enough and bladder neck is wide open. We placed a 10 French Foley catheter which was kept for 1 day, and it was removed on post-op day 1 and the patient was discharged. We advised patient to come for follow-up after 2 weeks for a uroflowmetry. This is the uroflowmetry report after 2 weeks. It's a good bell-shaped curve. with a Qmax of around 21 ml per second. We have informed the patient to come for a follow-up after 2 months with a repeat uroflowmetry and ultrasound report.